بسم الله الرحمن الرحيم. نتكلم على ال posterior only vertical screw instrumentation with intraoperative traction in the surgical treatment of severe scoliosis. We have learning objective in this lecture. Simply, the first part of the lecture is for general neurosurgeon to summarize the definition, etiology, classification, biomechanics of scoliosis, and identify different treatment options in severe idiopathic scoliosis and highlight the new treatment options in severe cases. Simply, scoliosis is defined as presence of one or more lateral curves of the vertebral column in the coronal plane, 10 degrees or more. I mean that less than 10 degrees, it is not considered scoliosis. It is just spinal asymmetry. ACT of scoliosis deformity, as we see that there is lateral curvature of the spine. The etiology usually is idiopathic, but congenital causes or other acquired causes may lead to abnormal lateral curvature of the spine. The classification is just etiological classification, idiopathic, congenital, and other causes. Biomechanics of scoliosis progression. Actually, this biomechanics is of idiopathic scoliosis. The key word here is rotation. There is no idiopathic scoliosis without rotation. Normally, in the dorsal spine, we have compressive forces in the ventral aspect and traction forces. Compressive forces, the ventral aspect, and the traction forces on the dorsal aspect. Thus, there is some sort of kyphosis in the dorsal spine or rotation of the vertebra of idiopathic cause. These compressive forces will be upon one side of the vertebra, making the concave curve, and the traction force on the other side of the vertebra, making the convex part. For measurement, this is the brain X-ray AB whole spine. For any case of scoliosis, we have what is called the proximal thoracic and the main thoracic and thoracolumbar curve. We have the apex, and the end vertebra is the most tilted one, and the neutral vertebrae. See that the pedicles are equal distance here. There is no rotation at the neutral vertebrae, and the stable vertebra of the spine that bisected by the center sacral vertical line. To measure the Cope angle, we need to know the superior interplate vertebra and the inferior interplate vertebra. And the line, intersection of these two lines will make the Cope angle. Idiopathic scoliosis is to be diagnosed after exclusion of any other cause. If we measure the Cope angle and see that the Cope angle is more or less than 70 degrees, we face now the severe degree of idiopathic scoliosis. We have many different options for treatment. Mainly, we have combined anterior and posterior surgery or posterior only surgery. Posterior only surgery usually transpedicular screws with or without osteotomy. A new plane of treatment, the use of intraoperative traction in conjunction with posterior pedicle screw instrumentation. It is usually indicated for curves more than 80 degrees. The cranial traction is by means of a hollow assembly by Gardner Verse tongues, lower limb skeletal traction through the distal femur or the proximal tibia. This is the Gardner Verse tongues in the cranial traction. Is proximal tibial traction. We can start with about 12 kilograms, 6 kilograms on the head, 3 kilograms on each leg. Weights are gradually and equally added to a total of 12 kilograms on each end. The total weight shouldn't exceed 30 to 50% of the total body weight. What are the benefits of intraoperative traction? It can elongate the spinal column, also elongates the thoracic cavity, improving the compromised pulmonary function. Help to assure the global body-pelvic alignment in large curves. And this is the most important for us. Helps to provide the maximum correction with little additional corrective force required with instrumentation. Is avoid the pull out. Is the case with idiopathic scoliosis. it is a severe case of idiopathic scoliosis. As we see, we have shoulder imbalance. The right shoulder is elevated than the left shoulder. Waistline is symmetry. Or leaning forward, we have the what is called the rib hump. Is plain X-ray, whole spine AB for that case. We have main thoracic curve, proximal thoracic curve, and thoracolumbar curve. It is a flavored triple major curve. We operate that patient by that technique: intraoperative traction, skull traction, tibial traction. Is the X-ray only after traction, without any manipulation. As we see, correction of about 50% or more by just traction. Is the intraoperative view, and after instrumentation. Is after instrumentation. And the photo post-operative. As we see, this is pre-operative, this is post-operative, pre-operative and post-operative. We can see this pre-operative X-ray after traction, after instrumentation. We can see that the maximum correction is obtained just only by traction. The pedicle screws add a little to that correction, but it maintains the correction. The use of intraoperative traction together with wide facet resection and the posterior release can gradually provide a good correction and balance that can be maintained by pedicle screw instrumentation. Traction radiogram under general anesthesia is the best method to predict the amount of surgical correction achieved by segmental pedicle screws, which provide even more correction. This helps us to avoid anterior surgery and related comorbidities. Thank you.